you. So now we are going to hear about another kind of family of interpreters that Professor Miyazaki mentioned earlier. And I'm going to pass the floor to Dr. Ayagoto. She's going to talk about talking and working with the professional community workers. Dr. Ayagoto is a public health doctor in the Fukushima Medical University.
Thank you very much for giving me this opportunity to share with you my activities in Fukushima. I am an obstetrician gynecologist by training and now working as a public health doctor as I was introduced in Fukushima. In a previous dialogue meeting, I presented with one of the public health nurses that I work with in Japanese. So this time, let me try in English to a wider audience. As Mr. Miyazaki, if I use the words of Mr. Miyazaki, I am a specialist interpreter in the field of public health. And public health deals with people's health, but it also deals with system. And I must apologize in the very beginning that my talk will be not as exciting as the previous ones. It'll be boring. I'm sorry about that. My activities in Fukushima are in threefold. First of all, I live as a local mother. My son is now 10 years old. And if I explain this in an academic way, it could be counted, I think, as a participatory observation approach of a qualitative study. Second, I take a part in the Fukushima Health Management Survey, especially in the implementation of a parenting counseling service based on the data that we analyze. Third, I work closely, as I said, with public health nurses and community, and recently my focus is on promotion of the keyword health literacy. I consider the skills of local health professionals to make the health information accessible to community residents as the key for bridging science and community. And today the focus of my talk is on the community side. Fukushima City, where I live and where my university is located, is about 70 kilometers far from the nuclear power plant, and it was within 50 miles US initial recommended evacuation zone. So you can imagine that especially right after the disaster, there were confusing and difficult messages about health risks of radiation. And naturally, mothers, including myself, were deeply concerned and some decided to evacuate. And during the first 2 years, we observed a 15% decline in the under 5 years old population within the city. And in order to respond to people's worries, there are many investigation commissions report, but let me take one of the Fukushima the reports, that is Fukushima Nuclear Accident Independent Investigation Commission's report led by Dr. Kurokawa. It says that information be disseminated for residents to make informed decisions. Very easy to say, but very difficult to do. Especially in the first 2 years, there were no guidelines. So, people who faced most difficulties were the public health nurses, who are the gatekeepers of community health in Japan. 1 month after the disaster, I got a call from a chief of public health nurses in Fukushima City, whom I have been working closely. She said, "Mothers are very concerned about radiation. We do not know what to do. Please help us find ways to help them. If you were me, what would you do?" And say and do. This is a slightly different conversation that I had with Dr. Jack Rochard a while ago. For working together in a difficult situation, building trust is important to work as a team. Nakayachi states that public level of trust toward government, in this case, is strongly associated with people's aligned value similarities. It is about a feeling of sharing the same value. And Jack explained to me that when we talk with a person coming to you to seek for an advice, we make it clear in the very beginning that I can't tell you what to do. followed by please tell me your concern and situation, and this will lead to active listening. And then we say, let's think together, so we can share the values. And only after sharing values and building trust, we can start explaining, in this case, the risks of radiation. And I was actually very happy to hear this, because this is what exactly I did when I received the phone call from public health nurses. First of all, on the phone, I requested the chief of the nurses to list major concerns of mothers and difficulties nurses face and send me the information. And I also arranged a meeting to discuss about the list. And before going to the meeting, what I did was to consult a psychiatrist, psychologist, and a radiation specialist. And the table right here shows what we discussed. In the first meeting, the aim was to respond to parents' immediate anxiety. And we decided about systematic information provision and setting up of indoor play spaces. In these meetings, my role was actually just to say yes. I just listened to the nurses, and when they come up with nice ideas, I said, okay, go, we will do it. Yes, that's a good idea. That was my role. In the second meeting, it was to respond to parents' persistent anxiety, and we decided a systematic screening of high-risk families, and also to strengthen individual and group counselings. In the third meeting, it was 8 months after the disaster, and we started talking about system, strengthening the system. And in regard to this point, we said the health information was necessary. So we started a project to analyze city data. Firstly, we decided to look closely at the existing city data from child health checkup files. We analyzed not only the quantitative data that were numbers to draw graphs and charts like on the left-hand side, but we also analyzed written records of parenting counseling, which is the people's voices. As for the quantitative data, number data, we looked at maternal confidence, and this is a commonly used indicator to evaluate the National Maternal and Child Health Plan. The proportion of mothers lacking confidence in child rearing increased 10% in the disaster year in 2011 from 50% in 2010. And this increase was interestingly associated with interpersonal problems at home, and I thought, what was that? When I looked at people's voices, the quantitative data, we found out that mothers were concerned about differences in risk perception. One nurse recorded, "Mother is worried about radiation and cannot let child play outside. Father says it is all right." So, what you can see is that one daily little activity becoming a cause of parental conflict. Secondly, nurses requested for learning and information sharing opportunities for themselves. So we started training workshops in various topics, and it is basically 1 hour lecture combined with 1 hour discussion. And I also analyzed their discussion notes. In the past 1 year, we organized 12 workshops and 270 nurses attended. And in September, 3 months ago, ICRP supported one of the workshops, and Astrid, who is going to moderate our panel discussion, gave a talk, and we discussed together. And these are the pictures. And the reports of all these workshops are uploaded in our university website. So if you're interested, please check later. And this workshop is actually conducted by the volunteers from 3 sections at our university: Public Health Department, Gender Specific Medicine Center, and Education Center for Disaster Medicine on volunteer basis. And we struggled to get a little money to run this for the past 4 years. And when I analyzed the city nurses' opinions, I found out they identify themselves as an important information channel in the community. But at the same time, they said that they needed to improve their communication skills. I really like what this one nurse wrote. We must say what we think about what we have learned, not just what the government says. So what it means is the public health nurses needed to understand difficult scientific information and be able to, not only that, be able to explain in the words that are understandable to community residents. It's such a difficult task to do. So from findings to actions. From the left-hand side, there is a simple diagram similar to the ones shown by Dr. Miyazaki and Mr. Omori about bridging science and community. And mothers were concerned about health risks, and the nurses needed to improve their communication skills. So in collaboration, as I said, with different sectors at FMU, we succeeded in scaling up the workshop from the city level to the prefecture level, and we now have a pool of lecturers. And I myself is repeating a health literacy training to increase their skills in risk communication. And the content of this health literacy training and its evaluation results, if you're interested, are described in the Japan Medical Association journal. Another good news is that the nurses initially asked me to analyze their data. But now they asked me to how to manage and analyze data on their own. So I am seeing an increased ownership of evidence utilization among the nurses. These are the pictures of the health literacy workshop. I give a lecture followed by discussions and presentation by the nurses about the findings. And these are the brochures piled up in the lobby of a health center in Fukushima City. And what I'm teaching is how to make these accessible to community residents. And let me explain briefly about health literacy. According to WHO, it is defined as individual skills to understand and use health information. However, this definition has expanded recently to include health professionals, our skills to improve the access to health information. So what it means is that if we make the information in an accessible way, we can lessen the demand put on people to try to understand the scientific information. And this is a table showing the content of a training. I'm sorry the letters are small, but in the first session in brief, there are 3 components, and in the first session we teach how to assess the accessibility of existing health information. And in the second session we teach how to improve the information, followed by 1-month application of the learned skills. And this slide shows what I actually teach. About the text, the sentences, I teach about its grade level and tell the nurses to write sentences that grade 6 students, including my son, can understand. And for the numbers, I introduce a concept of a numeracy level. There is a level for numbers starting from easy, simple counting up to the risk, which is one of the most difficult statistical concepts. And for the pictogram, I introduced a pictogram. For showing a simple 10%, it is much easier and the people can feel 10% if you list 10 people and mark 1 person instead of just showing 1 graph. And all these, for Japanese audience, what I teach is summarized in the isotope, the journal called Isotope News. And I am very thankful to this dialogue meeting because I met an officer from the editorial house of the journal in this dialogue meeting, and she was the one who invited me to write the article. And most importantly, for the communication aspect, I teach them a method called marker method. And this is for us to know what residents want to know and how much they understand what we say. And it is a very practical, simple method. Let me consider Dr. Van as a resident. Suppose this is a leaflet that I'm writing, and I take out one pen and ask Dr. Van, excuse me, this is the leaflet that I'm developing. Could you mark the words and sentences that you think that people don't understand? This is it's very simple as that. But there are two tactics. One is that we named it as a marker method. So the nurses can be proud of doing and saying, okay, today I am doing the marker method and going into the community and listen to people. The second tactic, I asked Mr. Van, please mark the words and sentences that you think your friends and people don't understand. I didn't ask you to tell me the parts that you don't understand, because I don't want to judge this person's knowledge, and that I don't want you to feel being tested. So such a little simple method can teach a lot about communication. And through the teaching, this is a little boring part. I found that this health literacy skill of health professionals at the individual level can be a strong driving force in improving health services and ultimately a health system at the organizational level. Why? Because it requires health professionals first to review goals of their health promotion activities to clarify what to tell to people. Second, they need to work as a team to develop and disseminate a good and clear health health information. And third, they need to work with community to make sure that their information appropriately address community needs. So in the end, to summarize, for the community workers to fulfill their responsibility to improve their community well-being, which is written in the right lower corner of the slide, they need to earn community trust. For that, they need training to build professional confidence to work with the community. And there are many skills to learn and many ways to build confidence. But for my case, as just one public health doctor, I am promoting health literacy as a key for professional community workers to improve their activities. This is the last slide. After learning health literacy, some of the nurses said to me that it is like looking community activities in the world through new glasses. Thank you.
Thank you very much. We have regained the lost time. Is there a question from the assembly? Also maybe later at the panels. Thank you very much.